Hey, welcome back to Not So Complicated, and today we will be talking about autoimmune encephalitis, its types, pathophysiology, diagnosis, and management, right? So let's begin without further delay. So what actually is autoimmune encephalitis? It is actually a group of disorders where autoantibodies attack neuronal proteins causing brain inflammation. So it is not a single disease causing affecting a single organ. It is actually a group of disorders, and they present with subacute confusion, seizures, or psychiatric symptoms often in young adults, and we will know how these symptoms appear in fewer slides to come, right? So it is also a USMLE trap because it mimics schizophrenia or viral encephalitis. So you have to know it in very detailed and in a like mindset of differential diagnosis, right? So you can see the image attached in here. It is an MRI scan of encephalitis autoimmune, obviously, and the white arrows in there are showing you the reason of inflammation, right? So let's talk about the types of encephalitis. It is based on the causative agents. The first one is bacterial encephalitis and fungal encephalitis, and then it can be parasitic encephalitis, it can be viral encephalitis, and the one we are talking about today is about autoimmune encephalitis, right? So you can see in the attached figure, it is a general pathophysiology. In autoimmune encephalitis, what actually happens is that an electrical impulse cannot get transported or stimulated to the postsynaptic neuron. And why is that? Because there are autoantibodies against NMDA receptors in postsynaptic membrane, and these autoantibodies like degrade those receptors, and that is how an impulse cannot get transmitted, and thus the brain stops functioning, right? So that is the general encephalitis like pathophysiology. Talking about them in detailed, autoantibodies obviously target synaptic or intracellular neuronal proteins, right? So the first autoantibody here is anti-NMDA that will affect glutamate receptor causing psychosis or seizures, right? The other one is anti-LG2 BGKC antibodies, and these affect limbic system causing limbic encephalitis, faciobrachial seizures. And the third one is anti-GABA B, and that will affect GABA receptor causing seizures and memory loss, right? So this is the pathophysiology, and the triggers of pathophysiology can be paraneoplastic or post-viral. In paraneoplastic, it can be due to ovarian teratoma as in NMDA receptor autoantibodies, or in SCLC it can be due to like HU antibodies, right? And in post-viral, human syncytial virus encephalitis can cause secondary autoimmune encephalitis, and the effect of these triggers is inflammation causing neuronal dysfunction, not destruction. So recovery is possible in this kind of things because it is not destruction, it is just dysfunction. If it was destruction, we all know that neurons cannot regenerate themselves, right? So recovery would not be possible, but it is just a neuronal dysfunction. So talking about clinical features, in psychiatric clinical features, there are psychosis, agitation, catatonia that will be leading to like NMDA leads to catatonia. This is a like homework for you. What is catatonia? You can comment it down, right? So in neurological thing, that is seizures, dyskinesia, or memory loss. So seizures that can be focal or generalized due to NMDA, LG2 autoantibodies, right? And dyskinesia, it can be orofacial, most commonly orofacial actually, and chorea. And chorea is actually like arrhythmic movement of hands, right? So hands or limbs or extremities. And memory loss, it can be due to lymphic encephalitis, and autonomic clinical manifestations are also there, like tachycardia, hypoventilation, and the onset is subacute, that is less than 3 months, and prodrome, that is these clinical symptoms are like they are preceded by flu-like symptoms due to NMDA antibodies, right? So you have to remember that. So in prodromal phase, there is flu-like symptoms. So how do we diagnose this case? We diagnose this case by CSF, that is cerebrospinal fluid, obtained from lumbar puncture. There will be mild pleocytosis or lymphocytes, and also normal glucose level, increased protein level, and oligoclonal bands in 50% of the cases in CSF. And then you can do antibody testing, that is CSF is preferred to serum, and anti-NMDA, LG2, GABA B, HU, MA2, these all are autoantibodies causing autoimmune encephalitis, right? So you can also do tumor screen, that is pelvis USCT, teratoma, obviously paraneoplastic syndromes, and CT chest, that is small cell lung cancer, right? So HU autoantibodies are appearing from that reason. So you can also do imaging or tests like EEG, right? So EEG, you can see seizures, delta bros, NMDA like this, right? And in MRI, you see limbic hyperintensities. You can see in the MRI figure attached there. So how do we manage this case? In the first line of treatments is IV steroids, but steroids cannot be, like in certain cases steroid is resistant to the patient, so we use second line drugs directly. So in IV steroids we use methylprednisolone and also plasmapheresis, that is done 5 to 7 sessions. And in second line drug we have rituximab, right, and also cyclophosphamide. So you don't have to remember the doses unless you are doing PG in neurology. And then tumor removal, that is teratoma, NMDA, SCLC, that is HU obviously. And the supportive management is that anti-epileptics can be given like levetiracetam, and that is 500 to 1000 mg BID, that is twice a day. Avoid antipsychotics because these antipsychotics can have dyskinesia risk, right? So the pattern of autoimmune encephalitis, these are different patterns. It can be limbic pattern and striatal pattern, perivascular, diencephalic or brainstem involvement, and then cortical pattern, or it can be MRI negative presentation. So in anti-NMDA you can see an MRI negative presentation, and only way you diagnose is EEG and CSF analysis and also proteotyping, right? So that is how autoimmune encephalitis is wrapped up. Thank you for staying with me, and please subscribe if this helped you.